In our cover story this week, Kate Andrews asks if the NHS is fit for purpose. She rather suggests not. She joins me now with Matthew Taylor, who's Chief Executive of the NHS Confederation. Now, Kate, Britain's been through a pandemic. We're bracing ourselves for whatever the consequences are of the Omicron variant. Of course, the health service is going to be stressed and strained. So why do you think that there's something more fundamentally wrong going on?
Well, as you say, Fraser, the pandemic has knocked not only the NHS, but essentially every developed country's healthcare system throughout the world. So, of course, it's going to be more strained. It's going to be in a more difficult state. But the truth is that the idea of a winter crisis is not unique to coming out of a pandemic or being in a pandemic. These are the usual headlines that we would see for the NHS nearly every winter for quite a long time now. The idea that you would pull the lever to cancel elective surgeries is also not new. We've been talking about that in the wake of the pandemic, the fact that in some areas they're being cancelled again, but that happened in 2018 because the healthcare service could barely cope. So what I'm highlighting in the article for the magazine this week is that yes, every country has had a very difficult time with COVID, and the strains and the extra demand as more patients who weren't seen last year are coming forward this year is going to be adding to that burden, although it's an important burden because those people should be coming forward. But the major difference is that we have known for decades now, when we look at international comparisons, that the NHS has been struggling. It's often ranked mediocre. It is far from the envy of the world. So I think now, coming out of COVID, hopefully, goodness forbid something should change on that front, this is the time that we need to start seriously talking about what the other options are. Not looking to the USA, which is usually the default, NHS versus USA, but looking to the rest of the developed world that also offers universal access to healthcare. But the emerging data does seem to be that many of those countries fared better in the pandemic and are faring better coming out of the pandemic.
Matthew Taylor, when you were working for Tony Blair, health service was pretty much half what it is now. It's gone from 8.1% of GDP to 13% of GDP for overall health spending. If money was going to be the problem, wouldn't we have the best health service in the world? I suspect even you wouldn't be as bold to say that we do right now.
No, I think our health service, and there are lots of different ways of measuring this, but it's probably overall funded slightly less well than similar health services. And it achieves outcomes which vary. In some areas they're quite good, in other areas they're not so good. So I think it's important not to believe that our health service is perfect, or even that it's, to quote a phrase, world beating, to recognise its strengths, but also to recognise that it needs to change. But it is very important to recognise that rising health costs is a global phenomenon, and particularly in developed countries which have ageing populations, because it is indeed the ageing of the population which is the big driver of health and care costs. I don't think there's anything intrinsic to our NHS model, universal healthcare, free at the point of delivery. That I don't think is what is wrong with the health service.
It's common to every country pretty much, isn't it? Every country in the developed world, apart from America, is free at the point of use.
Yeah, I think when we look at what we need to do with the health service to get it back on its feet, I think first of all, it is important to recognise that between 2010 and 2020, we had the decade with the lowest growth in health spending that we've ever seen in the health service history, around half the trend increase in health spending that you tend to see in countries because, as I say, of that ageing population. And the consequence of that was a health service with fewer nurses per head, fewer hospital beds, fewer doctors per head than most other countries like us. And a system like that, a system that runs on hot most of the time, is particularly vulnerable to external shocks. And that's why COVID has had a particularly challenging effect on our population and on our health service.
Right, but Matthew, that figure I quoted, 13% of GDP, that's higher than any country in Europe, any country in the world, except the United States. I mean, you cannot really say that Britain lacks for health spending, because we literally spend more as a share of our economy than anybody else beside the US.
I think if you look at public health spending, we rank below the average in the EU 14. We're just about average for the OECD. So you can look at this from various perspectives. Is it public spending? Is it private spending? Is it total spending? I don't, in a sense, the question of, as it were, this kind of existential question of whether or not the health service works, I'm not sure where it takes us. There is no public appetite for changing the core principles of the health service. Any attempt to do that would be massively disruptive, which is the last thing that we need now. I think instead we need to focus on the practical challenges that the health service faces, and also, and this is critical, the opportunities which are going to be provided by digital, by data, by med tech. Those offer the opportunity to make a real difference to our health service in the coming years. And I think that's really the thing we should focus on. How can the health service take advantage of those shifts to achieve a step change in the quality of its service?
So Kate, the health service is reasonably funded and it's doing a reasonable job.
Well, look, I think we can measure healthcare spending in all kinds of ways, but percentage of GDP spent on healthcare has often been the way that people look at it. And one of the reasons is because if you go back, say, a decade, the NHS was relatively average in the OECD. So that was a convenient metric to say that the issue is more money, we need more funding. That's always the go-to. Whenever the NHS has a problem, we simply say we need more funding. Now, this has changed quite radically and recently because Boris Johnson, after putting NHS pledges on the side of a Brexit bus, has really decided to double down on that, try to make the Tories the party of the NHS. And so far, he's not doing that with reform. He's doing that with money. But in 2020, the metric that is so frequently used to look at healthcare spending does put the UK second highest in all of the OECD. So those countries that are often cited for having better funding, Germany, Switzerland, France, that also get better outcomes, have fallen behind the NHS on that metric. And if we look between 2010 and what we estimate by 2025, the healthcare budget, the NHS budget, will have gone up by 42%. And I think if we look at something like schools, it's roughly 3%. In the next election, the day-to-day public service spending is going to be roughly 44% of the whole budget. We're getting quite close to having a healthcare service with a government attached. And I think it's very important, crucial, that in these next few years, given the fact that we have the system we do, we focus on getting those resources to the front lines and to supporting the doctors and nurses who are trying to help patients. But we cannot keep funneling money into what is so clearly a broken system. And the money that we were spending in 2020 just doesn't seem to, on the preliminary data, have gotten us the outcomes we would have wanted. Let's go back to lockdown last year. Look at the oncology appointments for cancer patients. In Germany, they dropped by 33%. That's a stark figure. But in the UK, they dropped by 60%. If you look at Swedish breast cancer patients, those that were being seen dropped by 10%. In the UK, it was 30%. With the money we were spending last year alone, we should be doing better on these metrics. So in the next few years, yes, by all means, let's try to be efficient. But we clearly have more to learn from other systems. And I think we need to stop being so blinded as to what they're doing right. Because as Matthew says, that principle of universal access to healthcare is so deeply important. But for the person waiting for their ambulance to show up who's losing hope, or for the person who still can't see their GP, free at the point of use is losing its relevance. The NHS is not there for them. And surely that is really the point, to get people access to care.
Matthew, what do you make of that point then, that non-COVID care during the pandemic was far worse hit in Britain than it was in other countries? I mean, Kate said that cancer care, for example, took a way bigger hit here than it did in Sweden. If you look at knee operations, hip operations, they went down far more here by about 45-50% than they did in Ireland and Italy, where they went down by about half of that level. So why is it, in Denmark they actually went up, so why is it other countries are able to carry on their non-COVID care, when in Britain we've seen that knocked for 6 and a waiting list of something like 5.6 million people?
So this is why it seems to me that bold statements like, the NHS is broken, the NHS doesn't work, doesn't really get us anywhere. It's kind of a level of generality which is fine for political posturing, but no good when it comes to actually practical steps. So why? Well, the simple reason is the way in which we run our health service has been to minimise the number of beds. Statistics are all over the place at the moment because of COVID, but one thing that was pretty commonly seen about our health service was that it was a pretty efficient health service, even if some of its outcomes were not what we would want them to be. If you talk to doctors even before COVID, and you talked about the occupancy rates we had in hospitals in the summer, people in other countries, continental Europe, would be amazed that we would have occupancy rates of 80% plus in the summer, when, in other countries this would have been unheard of. People would be taking holidays. There'd be a lot of give in the system. That's not how we run things. We run things so that, we do have difficult winters every winter. We do get people out of hospital as quick as
And that's
we
a
can.
good
We
thing,
do have
isn't it?
high occupancy rates. So when a crisis like COVID happens, there is no slack in the system. That's the way that our system has been designed.
But sorry, is that a good thing, do you think? I mean, it sounds to me like a pretty bad thing that we run it, bad for doctors, bad for patients, that every winter we seem to be in a crisis. I mean, surely there must be a better way. I mean, look, going to Europe, it doesn't happen to the same degree. Now, you're saying, yes, it's efficient if you look at the proportion of beds that are filled, but that seems to be a rather strange way of defining efficiency. If you define it for patient care, for example, if you define it in terms for patient outcomes, surely that's way more efficient than what proportion of the beds are filled. And isn't it the NHS way of doing it, maximising the bed occupancy, rationing healthcare? Hasn't that become the problem?
So I think if you look at the way in which the NHS has been resourced over the last few years, one of the problems has been feast and famine. You know, we saw a lot of extra money go in under New Labour. I think looking back, not as much reform, not as much progress should have been made. A lot was made. You know, by the time Labour left office, we were meeting those key targets for waiting lists, emergency departments, elective care, making real progress. We then move into these 10 years of austerity with spending increasing at less than half the annual global increase in developed countries that you expect in the health service. What that has led to is major capacity issues. So we have major capacity issues in terms of the capital of the health service, hospitals in a very poor state of repair, not made the investment we should have made in areas like digital. And of course, the number one problem right now, which is workforce. You know, we did not plan sufficiently, we did not invest sufficiently. And now actually we've got a situation in health service where in the short term at least there is the cash, but people don't know how to spend it because we don't have the workforce, because it takes several years to put that workforce in place. And yet even now we are pressing the government to publish more regular workforce plans, and there's a pushback against that. Why is there a pushback against that? Because if you publish workforce plans for the health service, it comes with a price tag attached, and the government does not want to see that price tag in the public domain. So it isn't just about the level of resource. Unfortunately, we've gone through this feast and famine, and that has left us in a position when COVID struck, where our capacity in areas like capital and areas like workforce was not where it needed to be, and we've suffered as a consequence.
So, Kate Andrews, Matthew Taylor is saying it comes back to resources. There was not much there was not much health spending during the austerity years. We're now looking at the consequences of that decision to slow down, and not exactly cut, but slow down on NHS spending when we should have been investing. The result, the disaster that we see now.
Well, to be very clear, the NHS budget was going up in real terms every year. It was just that it was going up perhaps less than others would have liked to see it go up. And I think a lot of this also comes down to priority about where the money that has been funneled in actually went to, whether or not it went to management or whether or not it went to the front line. It's very clear that some of those priorities were perhaps in the wrong order. I think Matthew's highlighted very well that this is a system that is intentionally designed to run hot. The way you argue you are efficient is to not have spare capacity, to not have spare beds, to not have spare workers, to always be operating on the brink. And I think COVID highlighted a lot of things. Number one, do you want a healthcare system that does that? But number two, with the NHS logo being used to convince people to stay home, protect the NHS. As I mentioned in an article, a senior source on the health side, on the NHS side, said, test and trace had nothing to do with us. They wanted to use that NHS logo because it's so powerful. That kept a lot of people home. Now they're coming back. The demand is rising. I still don't think the resources are in the right place. But this should make us question overall whether or not this is the kind of system that we can live with for the next pandemic, because if our freedoms are really tied to NHS capacity, it's going to be a rough life for all of us in the coming years, because as I mentioned at the beginning, NHS capacity is an issue every winter, not just with COVID. Then after that, I think you have to go back, frankly, decades, look at these international comparisons, and while we are all quite rightly talking about the value of life and what we all did on and off for the past 2 years to protect life, to respect individual life, we need to look at the fact that if cancer patients were treated in other countries from 4 of the most common types of cancer in, say, Germany or, say, Belgium, thousands more lives a year could potentially be saved. In short, the system really does matter. So this is a time, if you really want to protect that principle of universal access to healthcare, if you want more resources for the NHS, if you would like to see it better funded, and it is going to be better funded from next year with the Health and Social Care Levy, if you actually want to see that money put to good use, you have to address the system, and that's going to have to come from Whitehall, from the people in charge, and they're going to have to be courageous, because for a very long time politicians simply have not been able to criticize the healthcare service. It has become a national religion, but it is one that is not doing us any good.